Great. Thank you for having me. It's very nice to meet you all, and clearly um, uh, you all are doing very important work, and so I commend I commend all of you for really providing a service to patients who really benefit from this type of advocacy and support and whatnot. So, um, as Mike said, I'm a urologist, and in particular, I specialize in urologic oncology, and I do practice primarily in the space of helping patients navigate and get treatment for prostate cancer. And so, I'll be discussing a lot about. I know my title says Advancing Prostate Cancer Diagnosis Treatment, and mostly I'll focus on the diagnosis side of things today, and so. We'll get started. So, prostate cancer. Where is the prostate? The prostate is a gland, and it's located right here. So you have your bladder. If this is kind of a cross section through the pelvis. The bladder is up here, and the bladder empties through this tube called a urethra, and the prostate sits right over there. Okay, so it's located in the pelvis below the bladder. It's a gland, and it's useful for fertility. So, earlier in life for men, it's quite an important organ. Later in life, not as much, because it's really, that's its main focus is fertility. It's typically at younger ages the size of a walnut, but with aging, it can grow quite substantially, actually. Prostate cancer is a cancer that occurs starting from within the prostate gland. Okay, and it is the most common cancer in men. About 1 in 7 men in the United States will be diagnosed with prostate cancer in the course of their lifetime. It is a slow-growing cancer, and the majority of prostate cancers are not lethal. Having said that, some of them are dangerous, and so it is the second leading cause of cancer death of U.S. men as well. We do notice that prostate cancer is actually more common in the African American community. I stated that the global statistic is 1 in 7 men will be diagnosed with prostate cancer. About 1 in 5 African American men are diagnosed with prostate cancer. It is also more lethal in this community, and so the lethality is about twice as much as it is in white men. There are a number of risk factors. Age is the main risk factor. Age is not something you can control. Age is something that will just happen. And so, as men age, they are more and more risk of getting prostate cancer. The median age, the middle, the kind of the half of men are older than this age and half of men are younger than this age of diagnosis is 72 years old. It is felt that a kind of Western diet may have a role as well. Western environment, it's not totally clear which aspect of the Western environment, whether it's the diet or the atmosphere or whatnot, but something about kind of like living in North America does predispose people to prostate cancer. So much so that you can take the same person living in Asia, and when they come and live in North America, the risk of prostate cancer goes up. Family history certainly plays a role as well. Men with fathers or brothers or uncles with prostate cancer are more likely to get prostate cancer. About 1 in 8 prostate cancers can be attributed to family history. Incidence of prostate cancer, which means the occurrence of prostate cancer increases with age, such that if we were to look at try to find prostate cancer in men in their 80s and 90s, we would find that more than half of men would have prostate cancer. Those are cancers that are not significant, however, and that's an important thing to know. Many men die with prostate cancer, but not from it. How do we diagnose prostate cancer? Well, first there is the screening step, the step where we're just kind of trying to see if the person is at higher risk of getting prostate cancer. There is a blood test called the PSA blood test. PSA stands for prostate specific antigen. Okay, and antigen means kind of like a protein essentially, and this is a protein that's produced in the normal prostate. Prostate cancer makes more of it, and so if the level of PSA in the blood is high, it is either due to something like a big prostate just making a lot of PSA, but it can be due to prostate cancer. The other thing we look at is a rectal exam. You can see that the prostate sits right next to the rectum. And so finger can palpate the surface of the rectum, the prostate, and feel for any abnormalities. Of 1,000 men who get a PSA test, a quarter of them at some point in their life will have a positive test. A lot of these positive tests are not true positive. So the test may be abnormal, it may be high, but only 100 out of the 240 have cancer. So you can see a lot of men who get PSA screening do end up having a test that is abnormal. Not all of them, in fact, the minority of them, less than half, actually have cancer. If you have a positive test, if you have a test where the value is high, typically our cutoff is a value of 4. There's some nuance to that, but in general, that's the value that's used. Or the rectal exam is abnormal. The next step is a biopsy. The way biopsies are performed traditionally is using an ultrasound. An ultrasound helps us see the edges of the prostate, and then a needle is passed into the prostate to take samples of the prostate. The traditional way of doing this has been to do 12 evenly spaced samples. The hope is that if there's a tumor somewhere in there, that one of the samples will catch the tumor and diagnose the cancer. There is a little bit of a risk that the tumor could be randomly placed in between biopsy spots. There have been some advances on the use of, actually, before I get into that, there are a lot of kind of changes coming into this paradigm, which may be helpful for you to know if you yourself are facing the possibility of getting a biopsy or having to go through repeat biopsies because your PSA has been high. One is that one of the downsides of a transrectal biopsy, the biopsy that goes through the rectum, is that the needle passes through a dirty surface, the rectal wall, which has stool on it. This confers a risk of infection. And so one of the newer methods for doing biopsies has been to do what's called transperineal. The perineum is the skin right above the rectum. And so you can pass the needle through that skin. This is a slightly technically more challenging procedure to learn, at least initially. Once you learn how to do it, it's actually very reliable and very reasonable. Increasingly, more and more centers around the country are starting to do these. And this may be, depending on where you live, this may or may not be easily available to you, but it is an option to avoid the risk of infection. Once a biopsy sample is taken, the pathologist looks at it under a microscope. And what they're looking for is the pattern of the cells and how they come together. And a regular small pattern like this, because the prostate, like I said, is a gland, so it makes these like regular little circular structures. This is normal. Now, as those structures start to kind of devolve, you get these abnormal patterns. And so you go from a pattern 1 to a pattern 2 to a pattern 3, pattern 4, pattern 5. What happens is that the predominant pattern is characterized. So you look inside the sample of the core, and the pathologist may say, I see a lot of 3 and some 4. So they would call that a 3+4 cancer. Or they may say, I only see 3. That would be a 3+3 cancer. And that is what it constitutes what's called a Gleason score. The Gleason score is a characterization of how aggressive the cancer is. Okay, and the score goes from 6 to 10. So it turns out that 1 and 2 are not considered cancer, 3 and above are. And so if you have a 6 or higher, Those are cancerous tissues. There's a new system coming out, which I prefer. In my practice, I like to use this system. I think it's just more intuitive. I think when you hear a number 6 out of 10, it automatically sounds aggressive, even though it's not. But it just seems like a 6 out of 10 should be a kind of a high number. So the new system is called a grade group system. It goes from 1 to 5. It correlates pretty closely to the Gleason score system. There's some nuance in the 7. And so ultimately it goes from 1 to 5 and is another way to characterize the aggressiveness of the cancer. This is very helpful because the aggressiveness gives us insight into how proactive we have to be. If it's a grade group 1 or a Gleason 6 cancer, those cancers are very slow growing. There's time to make decisions. You can watch it closely with active surveillance, things like that. If it's a grade group 4 or grade group 5, those are very aggressive cancers. And typically kind of prompt action is important, maybe even kind of multidisciplinary treatment with surgery or radiation or hormone therapy or whatnot. One of the questions that comes up is, I did mention that the traditional way of doing the biopsy has been the 12-core biopsy. And one of the questions that was raised is, why do we still rely on random sampling to diagnose prostate cancer? This is actually a breast MRI. And if one was presented, even if you're not a radiologist, even if you're not a physician, you could probably identify where the abnormality is. Okay, and so if one was presented with this image, you would not go and proceed to do biopsies in this pattern. And instead, this would be the preferred way to do things. And so it actually turns out that the prostate is the only solid tumor in the body that historically has been diagnosed by randomly sampling the entire organ in hopes of hitting a tumor. Okay, and this has been actually linked to the lack of reliable imaging for finding the tumor, for localizing the tumor. And so there's been a lot of work, and this happens to be an area of my academic interest, of using imaging, especially MRI, to better identify tumors so that we can do more targeted biopsy. Part of the problem is that the older technology for MRI was just really not there and not good enough, and so these old MRIs used to give really blurry images. You really couldn't tell where the cancer was based on this. There are newer images now, newer technologies, a 3 Tesla MRI. Tesla stands for a strength of the magnet. MRI stands for magnetic resonance imaging. It uses magnets to come up with images. And the stronger the magnet, the better the image. And so older MRI machines were 0.7 Tesla or 1.5 Tesla. And the newer ones are 3 Tesla. There's actually 7 Tesla in development now. Those are not widely available, but they are in development. And they give very nice images. And so you can see the various structures of the prostate here. You can actually see the tumor. The tumor shows up as like a dark spot right there. And then there's a process called fusion biopsy, where the MRI image is overlapped in real time with an ultrasound, TRUS standing for transrectal ultrasound. And we can use that information to get targeted kind of bullseye biopsies from the prostate now. And so we've done actually studies on this topic now. And so Mike had mentioned that my journey kind of came through the NIH. And while I was at the NIH, I helped organize this study where we examined this type of biopsy in 1,000 men. And we found that the target biopsy actually improved the diagnosis of prostate cancer by 30% for actually aggressive cancers. So this was a major improvement. I mean, these are a third of tumors that were being missed by the traditional way of biopsy. Follow-up studies that our group has done has demonstrated that that there's still room for improvement, and that actually the use of the combined biopsy, that the MRI has made things better, but that combined biopsy with the 12-core template and the target biopsy is what's really necessary. And as I mentioned, there's still room for improvement. So there's actually a lot of technologies coming out to try to improve things. And so some of the things that I'll highlight is there is a technology called micro ultrasound, which is just a very high resolution, high definition ultrasound, which can actually maybe give some better insights into the presence of tumor. There's actually like advances in the space of MRI. At our center, for example, we're developing a new type of MRI called metabolic MRI. It's actually, the technical name of it is a hyperpolarized C13 MRI, and it may give information into like where there is activity within the prostate that is associated with cancer. And so none of these are proven. These are still kind of research areas. You know, these are not things that you would be able to go to your regional kind of community hospital and get access to. Even at academic centers, you would probably get access to them sporadically or under the guidance of a clinical trial or whatnot. But you know, in the next 5 to 10 years, we may see these types of things becoming more available. As the use of imaging has become more useful, the questions have actually arisen that should we change the paradigm of screening for prostate cancer? Right now, the standard way that we do screening for prostate cancer is we get either an abnormal PSA or a rectal exam, and that goes to biopsy. Okay, and sometimes you'll do MRI plus biopsy, but the point being, should we consider going from a PSA to an MRI, and only if the MRI is abnormal, then do biopsy? And there's actually some clinical trials now in progress to try to kind of answer that type of question. So we'll see where this goes. But this is the future. There's really pros and cons to doing a two-step process where we start doing MRIs on everybody. The pros are that there would be actually a huge decrease in the number of misdiagnosis of aggressive prostate cancers. And about 2/3 decrease in the number of biopsies that are performed. The cons are that if you start doing thousands and thousands of MRIs, the cost of healthcare will continue to go up substantially. The infrastructure is not there for doing this many MRIs currently in the United States. So, you know, if MRI became standard of care as part of screening, the number of MRI machines in the country would have to be substantially increased. Also, right now, experience in reviewing MRIs is not there, and that also would take some time to kind of make up the deficit. The last few slides that I'm going to end on are regarding treatment. And so for men who are diagnosed with prostate cancer, the treatment is not one size fits all. Really, it's very important to have a discussion with your physician on what the aggressiveness and the risk associated with your prostate cancer is. Compare that to other risk factors, competing risk factors in your own life, things such as maybe other medical issues that you have or other medical conditions and whatnot, and integrate all of that information to make informed decisions on, one, if you even need treatment for prostate cancer, and if you do, how aggressive that treatment needs to be. There is actually a lot of work being done to figure out how to optimally risk stratify men diagnosed with prostate cancer, and also to cut down on the over-treatment of prostate cancer. So it turns out that half of men have low-risk prostate cancer, and low-risk prostate cancer does not need to be treated. It can be actively monitored with active surveillance. Active surveillance is not walking away from the cancer. It's not letting it get away, get out of control. It's very safe. And in many cases, ultimately, it will need treatment, but you delay treatment. And by delaying treatment, delaying the side effects of treatment. There are significant urinary and sexual side effects with really almost any treatment of prostate cancer. And I really want to emphasize that any effective treatment of prostate cancer is likely going to have some degree of urinary or sexual side effects. The treatment options are numerous. Some of the most common ones are active surveillance, surgery, and radiation. There's emerging treatments such as focal therapy. Focal therapy has modalities such as like freezing cryotherapy or HIFU, high intensity focused ultrasound. Like I said, I'm not going to cover a lot of this. I am going to focus a little bit on active surveillance. I talked a little bit about improving the way we risk stratify patients. There is the use of different biomarkers and tests that are really kind of starting to bloom in helping us identify the risk tier that people are at in their prostate cancer. And so we talked initially about, there's PSA, of course, the PSA blood test. And of course, there's your Gleason score, the pathology score showing how aggressive it is. But then there's these other tests such as the PHI score, the PCA3 score. These are blood tests. There are genetic tests that identify the occult biologic potential. What is occult biologic potential? Occult biologic potential means the kind of like hidden ability of the cancer cell to act poorly in the future. Biologic potential meaning like the potential future behavior, and occult meaning like currently you don't see it, but in the future that's what it's going to do. And so the genomic tests such as Oncotype, Polaris, and Decipher are the most common. Are actually they look at the mutations in the DNA of the cancer, and the DNA is kind of like the instruction book. So depending on where the mutation happened, and depending on where that instruction book got garbled, right? You can have an instruction book with missing a first page, a title page, and it doesn't really affect your ability to use that instruction book, right? Or you can have an instruction book that's missing its middle page, and it really affects the ability for you to use that booklet. And so it's the same with the DNA. There are mutations in the DNA which are not of major consequence, and then there are mutations that can actually be a real problem. There are also tests out there that actually help identify tumor that might be missing. So, that you think you have a Gleason 6 cancer, but hiding inside the prostate is something a little more aggressive. And it's actually helpful to know that there's different tests for different purposes. So there's tests that test your existing cancer, and there's tests that can help you find cancers that was missed. MRI would fall in this category too, by the way. And so when we put that all together, we get these different risk categories, right? Low risk, favorable, intermediate, high, high risk, and advanced. And what's important to know is that for low risk, active surveillance is very reasonable. Whereas with intermediate, active surveillance may be reasonable, or focal ablation, or treatment of the entire gland. Whereas with the higher ones, treatment of the entire gland using kind of surgery or radiation or whatnot would be preferable. Active surveillance has been demonstrated to be safe and effective method to manage prostate cancer in properly selected men. This is now getting back to that low-risk population. It does involve the regular follow-up with the regular checks of the blood test, PSA, rectal exams, digital rectal exam, DRE, and repeat biopsies to kind of repeatedly assess, and initially every year, and then every 2 or 3 years as time goes on, that the cancer is staying stable. We also do repeat MRIs during this time frame to similarly follow. There is reported to be about a 15 to 40% rate of progression, meaning that the cancer becomes more aggressive during the follow-up period, and the need for definitive treatment. That's the whole point with active surveillance, is that the cancer you monitor closely so you can treat it safely within a window of like opportunity that still exists. And so you're not watching it until it like progresses to the point of like causing harm. You're just watching it to the point that you say that, okay, this is starting to get more aggressive and we're going to treat it now. Active surveillance remains underutilized. This is a little bit old. I've been looking for a newer graph and I've had a hard time finding one, but still to this day, the utilization of active surveillance is probably around 60%. In low risk patients. It should be much better. It should be almost 100%. Mike mentioned that that PCAI does some work, and it's been really a pleasure partnering with him and a number of other collaborators, including the patients program we have here at the University of Maryland, to put together a project which was recently funded through this institute called PCORI, Patient-Centered Outcomes Research Institute. And we will be putting together a conference, a patient-centered conference, where we'll be bringing together patients and researchers, clinicians, and academics to ask the question of how can we improve the use of active surveillance for the management of prostate cancer. And this is for people who appropriately should be managed by active surveillance. People who should be managed by it and yet choose not to get managed by it. This is very much a initiative which is grounded on the collaboration of the patient community and the clinicians to improve active surveillance. Like I said, it will be an open conference. It will be a virtual conference. It will be in kind of the late fall this year. If you would be interested in participating and attending it, you are absolutely invited, and we would love to have you. Please do get in touch with Andrel Metelier. She's our project manager for this project, who is helping kind of organize the project. And she will put you on a notification list so that once we have dates and registration links and whatnot, you will be invited to participate. And so I look forward to speaking with you all now. This is pretty much the end of the talk. And so look forward to speaking with all of you now, as well as if you are continue to be interested in this topic in the future. All right. Thank you for having me.